Good day, everyone, and welcome to another laboratory session in clinical bacteriology. Now, in this discussion, we will tackle the direct sputum smear microscopy and also the AFP staining procedure. Now, at the end of this session, the reader must be able to first, discuss the importance of this procedure to the laboratory profession. Second is to discuss the steps of DSSM or direct sputum smear microscopy. Three is to correlate the result of DSSM to diagnosis of the patient. And fourth is to discuss the reporting of the result in terms of direct microscopy. Now, let's start off with a quick background about um, the disease that is caused by the bacteria that are detected in using the DSSM procedure and the AFP staining, which is your mycobacteria. Specifically, your Mycobacterium tuberculosis, which is a causative agent um, of the disease called tuberculosis. Now, in worldwide class, TB or tuberculosis is the 13th leading cause of death and the second leading infectious killer after COVID-19, na above HIV and AIDS. The total of 1.5 million people died from TB in 2020, including 214,000 people with HIV. Now, in 2020 consensus, an estimated 10 million people po fell ill with tuberculosis worldwide. Now, 5.6 million in this population is men, 3.3 million women naman po, and then 1.1 million children. Now, in 2020, there is 30 high TB burden countries accounted for 86% of new TB cases. Now, 8 countries account for two-thirds of the total population. And these 8 countries are the following: India, China, Indonesia, Philippines, Pakistan, Nigeria, Bangladesh, and South Africa. Unfortunately, the Philippines is among the 8 countries now that have um, 30 high TB burden account. TB, it has account for 86% of new TB cases in 2020. Now, an overview of the Philippines tuberculosis roadmap, which is in the fiscal year 2021, it is estimated to have a 599,000 active TB cases. Now, in that sense, no, our TB burden, our country po is ranked as 7th in the MDR TB burden countries. When we say MDR class, it is the multi-drug resistant TB, which is hardly to treat na because of its um, resistance to most of the commonly employed antibiotics for killing tuberculosis or killing the Mycobacterium tuberculosis. Now, tuberculosis po is caused by a bacterium po called Mycobacterium tuberculosis. Now, the bacteria usually attack the lungs, no? And then it can also attack other um, organs such as your kidney, spine, and the brain. Okay? So, two TB-related conditions exist. So, this is your latent TB infection and your TB disease. So, when your Mycobacterium tuberculosis resides in the respiratory tract, the disease is called PTB or your pulmonary tuberculosis. When your bacteria naman po, the causative agent po, no, infects other organ besides the primary organ, your lungs, it is called naman po extrapulmonary TB. So when the bacteria infects kidney, spine, and the brain. Now, how do you diagnose TB disease? Now, the TB po is diagnosed po by medical history, the physical examination of the patient, checks X-ray, no, and also laboratory tests. Now, TB disease is treated by taking several drugs, no, as recommended by a healthcare provider. So these drugs usually are your isoniazid, rifampicin po, no, and ethambutol. Okay, so let's now discuss the laboratory identification of tuberculosis. Now, for the Philippines, no, the DOH po, no, established po the manual of procedures po for the DSSM and AFP screening procedure. And this manual po has a complete no um, mandation, the procedures po, and the specifics po when it comes to testing, diagnosing, testing po patients with suspected to TB case. Okay, so usually the diagnosis and testing po starts with a requisition form. So this is called the form 2A, no, in the manual. the laboratory request and result form for DSSM po. Okay? So usually po the form you need to submit it before you need to comply with it before you pass your specimen in the laboratory. So this is checked thoroughly no by the medical technologists no in on duty no for it to be completed no and the information of the patient is reported. So yung mismong information po dapat po kompleto, the demographics and others kasi pag nire-report po ito completely to the DOH, no? Now, let's start off with the pre-analytical procedure of the test, which is the collection and transport of the specimen. And usually po, the commonly submitted specimen for subject for DSSM or AFB staining would be your sputum specimen. Now, the manner of collection of the sputum is that you instruct your patient to expectorate sputum sample. So you do not allow po um, employment of saliva, no, it needs to be deep cough, okay, expectorated cough, for you to have a better representative of mucus po coming from the lower tract of your lungs. Now, usually two types of sample is submitted, the spot sample or the early morning sample. When we say spot sample, on the spot, no, you collect po no the sputum of your patient so in any time of the day. When we say early morning naman po, you instruct the patient to um, do no the expectorated sputum early morning po in the house and then submit the specimen po early morning no to be processed. So usually po no um uh 2 to 3 no firstly submitted or first time submitted specimen po is processed for um patients po that are suspected with or first time suspected with TB. Okay, so 2 to 3 specimens po should be submitted, and these specimen usually are early morning specimen. Okay, and then in terms of rapid detection, we can use molecular techniques such as using expert or TB lamp no machines no for quick detection. Okay, but it is usually done po on first cases um of patients, so yung rapid. So usually po to in follow up checkups or testing, we do not usually do expert no um but in certain cases po no some doctors pa rin request for an expert testing no for follow up no for detection of progression of the disease and also the existence of the MDR-TB in the patient. And then in other methods, no, we use smear microscopy. This is the commonly um, used method using AFB staining procedure. Now, to go deeper with the the pre-analytical process, the collection. So, in this slide po, gives you the detailed procedure in collecting the sample. Now, in collecting the specimen po, it needs to be collected in a well-ventilated, designated sputum collection area. So, bakit ganito po kataas ang restriction or containment starting from the collection? Because your bacteria po, no, can aerosolize or it can be airborne. So your Mycobacterium tuberculosis can go with the air and then be transmitted on a longer distance from other patients. That's why no, it needs to be a well ventilated and a designated room for collection. So usually it is outside the health facility. So, as you instruct the patient, so these are the specific instructions no, before collection and within the collection. So, you instruct the patient on how to expectorate. No, first, before you expectorate po, or before the patient expectorate, you need to, or the patient needs to clean his or her mouth no, by thoroughly rinsing with water. So, do not use mouthwashes. No, you need to just rinse your mouth with water. So, for you to avoid um, um, po adding no food particles no in the sample. So breathe deeply, no, and then hold the breath for a second or two, and then exhale slowly. Then repeat the entire sequence 2 or more times to induce the coughing mechanism. Now cough strongly after inhaling deeply for the third time, and try to bring up the sputum from deep within the lungs. And expectorate the sputum in the sputum cup or conical tube. So the cup po should be a screw type, no? And then wide mouth. Now, additional instruction po for the collection of the sputum is that, again, you gargle with lukewarm distilled water, and then prior to collection, do not gargle with mouthwash, do not brush your teeth also, no, and then do not eat or do not drink, no, especially coffee, alcohol, or tea, no, nothing per orem po ang instruction. Now, these are the requirements po in the sample collection of your sputum. The source of this information would be the National TB Control Program Manual of Procedure of DOH. Now, early morning sputum po is usually submitted, not spontaneously produced, not pulled, and it is the preferred specimen for AFP staining, the early morning sputum. So, if patient is ambulatory, use aerosol induced, using a hypertonic solution or hypertonic saline for collection. Then the quantity, that needs to be submitted should be at least 1 teaspoonful or 5 to 10 ml of sputum for DSSM. For expert naman po na testing, the expert MTBRIF, sputum sample should not be less than 1 ml. So the minimum amount would be 1 ml. But for the DSSM, it needs to be increased now 5 to 10 ml. So this slide shows you the assessment mo of quality of the sputum. So please take note at the leftmost portion of this slide. So this type of sputum should be avoided. Yung excessive saliva, no, and then inadequate po yung amounts of mucous material, okay, or sputum material. So usually po we check this the quality of this type of specimen by microscopy procedure. We count the cells po, your epithelial cells against pus cells. And then the right ratio po should be the pus cells must be higher in counts compared to epithelial cells. So if the epithelial cells is higher, no, the sputum is suggestive that the sample is there are lots of saliva. So wala pong representation of the sputum because their saliva po contains higher amounts of epithelial cell. So on the other hand, no, on the center, no, this would be the preferred one, no. So as you can see here physically, no, there are an adequate amount of the representative sample. So usually the right physical state of the sputum should be it is yellowish or greenish um sample, no. And then on the right part naman po is a blood stained sputum, no. So we can process a blood stained sputum, no, provided that the sputum po, no, should is not subjected to expert MTB reef, no. So if blood tinge po, the usually po the part without the blood tinge is usually subjected to expert MTB reef. Okay, another notes to remember is that for smear microscopy, you instruct to collect a second sample 1 hour later or an early morning sputum sample the following day. So this is to allow an increased accuracy in terms of the detection of TB bacilli in the sputum. Now, follow up within 3 days now if patient fails to submit a second specimen unless the first specimen is already tested positive for acid fast bacilli, in which case the second specimen will not be necessary. So usually the follow-up submission of another sample po is usually done, no, to samples that in the first testing it is negative. Now to confirm po usually rin, no, we instruct the patient to collect another sample for the next morning. Now, let's now proceed now to the analytical phase, which is the testing procedure of the DSSM and doing the AFB smear. Okay? So, first things first, we need to do a properly done smear for AFB staining. So, for standardization purposes, no, the three important parameters to consider to produce a well done um, smear in a sputum sample are the following. So it should have a standard thickness, a standard evenness, and standard size. And the type of way no of doing the smear of the AFB smear is called coiling process. So the coiling process allows the um, achievement no, of these three important parameters: the proper thickness, the proper evenness, and the proper sizing. As you can see here po, no, mayroon pong standard size and standard thickness and evenness yung smear. Because later on kasi we need to count no, specifically or quantitatively po the number of bacteria po in the smear itself. So that's why the parameters po should be standardized. So what would be the standard size, no? Now, the standard sizing of the smear for acid-fast bacilli staining would be, or it should be, 2 cm by 3 cm size. Okay, so typically it is oblong shape or thumb shape in appearance, and the size po is approximately 2 cm by 3 cm. Now, in this slide naman po shows you the right thickness, no? No, as you produce the coiled smear in the process. So the we avoid po no too thin smear po because it can be washed off no in the staining procedure. Too thick smears naman po, we should also avoid it no because it will overstain and it will cover po the bacteria that we need to detect with. So we need to observe po the proper thickness. Let's now discuss now the acid-fast staining procedure. Now, the acid-fast staining po, it is used to stain bacteria that have high lipid content in their cell wall. So, these are your mycobacterium bacteria, okay? Now, the principle of this acid-fast staining method is that the primary stain, no, binds to the mycolic acid in the cell wall of the mycobacteria and is retained after decolorization with acid alcohol. So, if the primary stain is retained, that is called acid fastness. Okay? So usually po the procedure po or step-by-step procedure of the acid fast stain is the general procedure for differential staining, which is it has a primary stain, a mordant, a decolorizer po, and then a secondary stain. Now, as in the case of acid-fast staining po, usually we use carbulfuchsin for the primary stain, which can color the acid-fast bacilli as red. Okay? Now, for the secondary stain naman po, we usually use methylene blue and malachite green so as to color the non-AFB as blue or green, respectively. Okay? So, usually resistant to decolorization po yung ating mga non-AFP natin. Now, non-acid fast don't contain mycolic acid and become decolorized with alcohol. So, usually we employ the primary stain and then the mordant. Now, the mordant usually in acid fast staining procedure are your heat or your tergital chemical. Okay? So, for your decolorization, we use acid alcohol naman for your acid fast stain. Okay? And then for secondary stain, it can either be methylene blue or malachite green. Now, in this slide po shows you the different staining methods now used in different situations. Okay, so the two most commonly used here are the following: your Zil-Nielsen method or the hot staining method, which uses steam or uses physical mordant or heat, no, that acts as a mordant in the primary stain. Now, the hot staining method po, historically po, is developed by Paul Ehrlich in 1882 and it is modified by Zill and Nielsen. The next one would be your quinones or your cold staining method. This is called cold staining class because the mordant here in the quinone is not heat. Okay? So it omits heat. It uses po a carbulfuchsin with higher concentration of phenol, which serves as a chemical mordant. So sometimes it has a wetting agent called tergitol, no, to fasten up reaction. So in your Kenyon's method, it uses a high concentration of phenol. Okay? So naturally kasi your carbolfuchsin contains phenol po. Okay? and usually po in 5% in Ziel-Nielsen. While your quinine po, it has a higher percentage of phenol, about 9% phenol, which acts as the mordant or chemical mordant. Okay? Now, next naman po is your Pappenheim's method, which is used specifically to demonstrate Mycobacterium smegmatis from M. tuberculosis. Baumgarten's, on the other hand, differentiates M. leprae from M. tuberculosis. And lastly would be your Oramin Rhodamin method, which is a type of fluorescent dye or fluorescence method, which selectively stain po the cell wall of your AFB. So the AFB appears bright yellow or reddish yellow po in the Oramin Rhodamin method against a dark background. Okay, so mycolic acid renders the cell resistant to the colorization. So thus the term acid fast. So the heating and staining process po, it is used to temporarily remove the mycolic acid while the smear is flooded with the stain. So please take note that mycolic acid is a type of a waxy substance. So as you heat it, now it will be dissolved non-permanently, and then it will allow the seepage po of the primary stain. Now, once you eliminated the heat, now the mycolic acid will return to its original state, locking the stain inside the cell wall. Okay? Now, sometimes po we do not use heat, no? So we use a higher concentration of dye and phenol in the other hand. Now, example of this is your in your Nielsen stain, okay? So naturally, no, your carbolfoxin is in 3 grams and 5% concentration in phenol in your Nielsen, while your quinones naman po contains higher amounts of carbolfoxin and concentration of phenol po. So this allows the non-usage po of the heat mordant in the process. Now, prolonged contact of the specimen with the primary stain, it is a type of to facilitate acid-fast staining, and then addition of a wetting agent, which is erythritol. So erythritol is a type of detergent, okay, which greatly accelerates the staining of the acid-fast organism and made heating of the slides unnecessary. Now, the quality control for Ziel-Nielsen and Quinion methods are the following. For positive AFB, our representative would be your Mycobacterium tuberculosis, ATCC 25177. For partially positive AFB naman po, we use Nocardia asteroides, ATCC 3308, for the positive partially AFB result. Now, for the negative non-AFB result, we use naman po a non-AFB bacteria, which is your Escherichia coli, ATCC 25922. Okay, so let's now discuss the general rule of the AFB staining method. So tandaan nyo po, or please remember, all bacteria are non-acid fast except for the following. So these are the examples of the acid fast bacteria. First is your Mycobacteria, and then Nocardia, Rhodococcus, Chucamorella, Gordonia, and Legionella mictadae. So these are the examples of acid fast bacteria. Okay? So the non-mycobacterial organisms naman po, some non-mycobacterial microorganisms possess some degree of acid fastness. So examples naman po of partially acid fast non-mycobacterial non-mycobacterial organism is your Nocardia, Rhodococcus, Cryptosporidium, which is a type of a parasite, and then Legionella mictadae. Okay? Now, the positive modified acid fast staining naman po na parasite would be your Isospora belli and Cryptosporidium and Cyclospora. So, when we say modified acid fast staining po, ito po yung tinatawag na modified Quinion method, which is ang nagpa-positive po siya would be your parasites. Now, this shows you the simple procedure po of the Ziel-Nielsen staining or the hot method. So, usually po, it is a step-by-step process which follows po the application no, of the different reagents. Your primary stain. So, usually the step is just simple. No? You flood the stain no, with the primary stain and then apply heat as a mordant for 5 minutes. Then after doing so, now you apply acid alcohol to decolorize the non-AFB. Now after doing this, you apply now the secondary stain to stain the non-AFB. Okay? Now, after po doing the simple procedure, you can now proceed to the reading process. Now, the proper way of reading glass is here, okay? So, usually po the label is placed no, at the rightmost portion of the slide. And then on the whole smear glass, you do in total a 300 field reading. So, this is done by a 150 no, and a right on the right side, and then 150 field po on the left side po. In the total po, that is 300 300 oil immersion fields. Now, how do we interpret the results for both bright field and fluorescence microscope? So after counting the cells, no, or observing po if there are positive AFB, which is color red, in your smear, no, in your 300 fields po, you can now report uh, the numbers you count po in your smear. Okay? So this is based by IUA-TLD or WHO scale. Okay? Now for bright field microscope, when you do not observe any MTB in your process, it is reported as no AFB seen in 300 oil immersion field. Now, in usually po, if in one length class, you observe lang po lesser than 10 na bacteria in the whole length or one length, ibig sabihin 150 oil immersion field, you report the actual number. Okay? For example, you report 3 no bacilli po on the whole 150 field, you report is as the actual number. Now, if you count po 10 to 99 AFB in one length or in one 150 oil immersion field, you report it as 1 plus. Now, if you happen to count naman po 1 to 10 AFB no per oil immersion fields at least 50 fields, you report it as 2 plus. That is quite alarming na. Madami na siya. Okay? And then if you count more than 10 AFB no per oil immersion field at least 20 oil immersion fields, you report it as 3 plus. So that would be the reporting of or interpretation and reporting of your AFB stain. Now, in the slide po shows you the result no of a smear po with a positive AFB. Okay, as you can see here, no, the red bacilli po existing here are the AFB, and then you count it po no every field. Then we will report it. Now, in this slide naman po shows you an example of a 3 plus reporting of AFB stains. As you can see here, you cannot count it na po. So, usually per field, if it happens po na ganito kadami, you report it as 3 plus. And then, but you count muna po no, at least 20 oil immersion fields to confirm. Okay. So, discussing naman po the other type of acid-fast staining would be your modified acid-fast. So, usually naman po it is used for the identification of intestinal coccidian OOCs, your Cryptosporidium and Cyclospora. Okay? So, usually it is done in stool specimen po, freshly collected or preserved in formalin. And usually the reagents po is the same with the conventional acid-fast reagent, except that the concentration of acid alcohol is 1% sulfuric acid or mas milder po siya. Now, the result will be a magenta stained organism no, against a blue background. Now, notes to remember about the AFB is that mycolic acid po renders the cell resistant to decolorization, thus the term acid fast. Now, acid fastness is affected by the following: colonial age, medium for growth, and ultraviolet light. Now, the Zil-Nielsen method is the ideal for concentrated smear no, and partially AFB like nornocardia. Now, the modified quinine naman po, on the other hand, is ideal for um, Cryptosporidia and Cyclospora parasites in stool specimen. Now, let's now proceed now to the procedure po of acid-fast staining. Now, the classic acid-fast staining method, which is your Zil-Nielsen po, requires heat to allow the primary stain to enter the wax-containing cell wall. Now, a modification po of this procedure, which is your Kenyan acid-fast method, doesn't require heat po or boiling water to minimize po safety concerns during the procedure. Now, to done this, no, you allow a higher concentration of phenol in the primary stain solution. So, rendering po the heat unnecessary. So, this modification is referred to as the cold method. Now, to summarize po the equipment and materials needed. So, for reagents po, you use aqueous carbolfuchsin, acid alcohol po, and methylene blue. So, your aqueous carbolfuchsin is the primary stain, the acid alcohol is the decolorizer, and the methylene blue is the secondary stain. Equipments are the following: Bunsen burner alcohol lamp, alcohol cleaned microscope slide, applicator stick, tripod, aluminum foil, and water. Now, the step-by-step process of the preparation of sputum smear are the following. So, first is to carefully open no, the vial po containing the sample inside a safety cabinet. So, do not open AFB samples in the open as AFB is transmitted via aerosol. Okay. Now, transfer an appropriate portion to the labeled slide by an applicator stick, disposable inoculating loop, and then choose the solid, bloody, and grayish part of the sputum. Okay. And please take note that the disposable inoculating loop and applicator stick should be disinfected first before disposal by means of submerging it inside a container with sand and sodium hypochlorite solution. So always disinfect and practice aseptic technique before and after experimentation. Now, the next thing to do is that you make a 3 cm by 2 cm length and width with oval translucent smear, not too thick nor too thin, and then allow to air dry for 15 minutes. So to hasten this air drying process, you can use a warmer plates, no? Para mas mabilis po na matuyo yung ating smear. Now, fix by framing while moving the slide in a circular direction so as to prevent localized heating. Do not overheat, no, as it will disrupt the natural components of the cell wall, thereby decreasing the efficacy of the staining procedure. Then cool the slide before staining po. Now, proceeding in the staining process, now you prepare naman po and fix the specimen smear prior to staining. Now, the first thing to do is you flood the slide with the aqueous carbolfuchsin solution, and then using a low flame, steam it for 5 minutes. Now, in the staining process, you can use a um, a water or boiling water, or you can also use direct flame. Now on the underside of your slide. Okay, so make sure that the preparation does not dry up by placing a strip of blotting paper or filter paper po onto the slide and adding more carbofuchsin from time to time. Now, after doing so, you can wash off the excess stain with water. So the recommended water would be distilled water. Tap water cannot be used because environmental mycobacteria can contaminate your sample. Now, on the next step naman po, after washing off, is to decolorize the smear with the acid alcohol by adding alcohol in small amounts, drop by drop, no, for 30 seconds until no more stain comes off with the alcohol. Okay? Now, next thing to do is to counter stain it with methylene blue for 60 seconds and wash off the excess stain with tap water or preferably distilled or sterile distilled water and air or blot dry the smear and examine it under oil immersion film. Now, after po the staining procedure is the reading process and interpretation. So, how do you do your microscopy? Now, first thing to do is please take note that one should view a minimum of 300 fields before a slide is called negative. So, you do this by reading the whole slide from left to right, this which is equivalent to 150 fields. Now, go down one field and read it from right to left. This is equivalent to another 150 fields for a total of 300 fields, and then record your result. Again, the acid-fast organism, the Mycobacterium species, will appear red, and then a non-acid-fast organism will appear blue. In addition, the background material should stain blue also. An example of a slide with a positive AFB is represented here. Now, proceeding in technicalities, what are the causes of false positive acid fast smear? These are the factors that causes false positive result. So changes in the cell wall, okay? So excessive heating and other matters, insufficient decolorization. You do not allow the complete decolorization. Laboratory contamination. That is why we need to recommendly we use we do not use tap water for washing. And then delaying of process and overgrowth of other bacteria will also cause false positive acid fast smear. Now, what are the causes of false negative acid fast smear? So, first is your overzealous decontamination. Okay? So, decontamination kasi po is done before you process your sputum. Okay? And too much decontamination can kill, no, the necessary bacteria to be examined. Loss from oxygen concentration techniques can also cause false negative. Organism obscured by a very thick smear. So, that's why you need to properly do your smear. Now, over-decolorization can also cause false negative. Poor counterstaining, no? Um, you have a lesser contact time of the counterstain. So, you need to observe the contact time. Now, and then lastly is the lack of observer proficiency in reading sputum smear. You overlook po the red bacilli in your smear.